Okay, hold on 1 second. Sorry about that. Okay, so I think we are working on that. Again, I'm sorry about that. And can you guys now see?
Yes, we can see it now.
Okay, so we're good. Okay, so we're good now. Okay, here we are. Okay, so let me just make a slideshow. Okay, yeah, here we go. So some facts. So we're good now.
Yes, doctor, go on.
Okay. So some facts about ER, as I mentioned before, it encompasses an understanding of the development of the pre-hospital and in-hospital emergency medical services. So we are not dealing just with the patients who are coming into the ED, but also we are dealing with patients who are coming by the help of our colleagues from the emergency medical services, which we really appreciate their help during our job. And also, it's extremely challenging environment, as I mentioned. So you will deal with different types of patients. You have the difficult patients. You have also difficult family. And also you have to be dealing with some issues regarding the administration. You have to deal also with the ambulance outside and the arrangement of the ED, the flow of the ED. So it's kind of a challenging environment when you work in your shift. And we are available and prepared at any time. So we are prepared and available like 24/7 in the whole year, 365 days. And just for your information, the first resident who was in the ER, like in US, started around 1969. And the first residency program, if you can imagine that, it was in 1970. So it's kind of a new specialty that we are dealing with. So next, so what we are doing in the ER. So basically, we do triage. So triaging patients, like when the patient coming to the ER, we have like a visual triage by one of the nurses who just look at the patient only by eye. They don't have any other job except for just looking at the patient who is coming toward the ED, and they are the visual triaging the patient. And there is another nurse, triaging nurse or a physician, who also do the triage like by manual triage. They will ask about the chief complaint, and also they will take sets of vital signs. And then they will categorize the patients according to the chief complaint and the vital signs and the status of the patient. According to that, they will triage the patient if it's really sick patient, or this patient can wait outside for a little bit, or this patient is not an emergency department and can be triaged away. So the triage is one of the most important things in the ER. The other thing is the assessment, which once the patient comes in to the ED, the patient will be assessed by physician, and like taking the history and examination, and then next will be the diagnosis, which sometimes some patients, they don't need to add any investigations for them. You can just by history and examination, you know what's going on, and then you can take the decision for this patient. But some patients, no, the investigations will add up to your differential diagnosis. And then you'll start the management. according to the patient situation. Sometimes these 2 or 3 things can be interchangeably. I mean, the patient can be managed first before doing the diagnosis because it is something critical. I need to give something now in the ER, which makes our specialty special because we can play, like we can change the rules. And then when you start the management then you have to decide, where is this patient going? Is the patient going home? Is the patient going to be admitted? And even if admitted, going to be in the floor or going to be admitted in the ICU? So what makes emergency medicine special? So knowing the patient is sick or not sick, this is really, really, really challenging. And the only specialty can know which patient, which is sick and which is not sick, most probably the emergency physician. By entering the ED door, so the physician can just take a look at the patient and they say, oh, this patient is really sick. He's tachypneic. He's really in shortness of breath. Or that patient, he's not sick. He can wait a little bit. So this is one of the things that makes the emergency medicine special. And also the quick rapport. So the quick rapport is like when you meet the patient, like how to build a good relationship with the patient, because he's not your enemy. You want to help the patient. So once you build a quick rapport, so it's going to be easier for you to get the information that you want from the patient, and then you can deal with this type of patients by building a quick rapport. And we know that it's a very short time because it is in the ED, but once you do something good for the patient and you're going to meet him or her outside the hospital and they will see you there, they will say, oh, thanks, doctor. So you did great. You helped me doing this and that. So it's kind of good opportunity to build a quick rapport with the patient. Next is going to be the critical decision making. It's also one of the things that makes us special, is the critical decision making. Sometimes you don't have to wait, for example, for the results. I mean, for example, you have a patient who is coming with myocardial infarction. You look at the ECG, and you see this patient having some ST changes in one or two leads. And you say, hey, this patient, he is really critical. He needs to go to the cath lab. I mean, you can take a decision about this patient, which the emergency medicine gives you this opportunity. Multitasking, yes, definitely. For emergency physician, multitasking is, you should be a multitasking person during your shift. So you have your colleagues, you have like the other physicians around you. You have nurses working with you. You have technicians that also working with you. You have the admin, people also. You are working with them, and also the EMS people. So you can multitask yourself. So you can see different patients, and you can prioritize yourself about which every patient needs, or what every patient needs, and you can multitask that. You can give orders about this patient, and then go outside and talk with the EMS about one patient critical is coming, and go back again and talk with the admin regarding dispositioning of one of the patients. So the emergency medicine gives you this opportunity to be professional about multitasking. Teamwork, again, it comes with when you work a lot of shifts with your colleagues, with your friends. It is a teamwork. So we can't do everything by only one person. We are working in a teamwork. I can do my job, and my friend can do his job or her job, and we can do a teamwork for the benefit of the patient. Next is going to be the episodic care. So episodic care, it means like you don't have this, like it is rarely that you have those days that are you don't see a single patient. No. So you have those days that when you see a patient and suddenly you have like gush of patients, like 7 or 8 patients, you are seeing them at one time, for example, and then you will have again a rest like for about 1 hour or half an hour. So also the emergency medicine gives you this opportunity of episodic care. And what's the appeal for emergency medicine? So it makes an immediate difference. I mean, the patient who is coming, for example, with a fracture of one of his leg bones. So since the patient arrived and like, let's say 6 hours or 8 hours after that, definitely you will see a difference, a change happens to this patient, which also makes it good for you as an emergency physician. Let's say, okay, so I have a patient who was really sick, like shortness of breath or tachypneic, and now after 2 hours after you are giving him or her nebulizer, for example, you are treating him. So then you'll see the huge difference on his status. Again, I mentioned that before, undifferentiated patient population, like you have a variety of patients. You will see pregnant patients who are less than 20 weeks. You will see pediatric cases. You will see also some different, like, for example, oncology patients, cancer patients. You will see, for example, like surgical cases. I mean, it's like variety of cases and population, you would say. And also they have this taste of the challenge of anything coming in. I mean, I'm sure for those who work in the ER, I'm sure at least they saw one case that is really, we can say it's a weird case, or it's something different that you haven't seen this before. And you will tell your friends about the case that I saw one case like this and that. So it's kind of really fun that when you have this challenge in the emergency medicine. Again, emergency and invasive procedures. So some procedures, they save lives. I mean, like intubations, putting a central line for patient who is hypotensive and they want some pressors to keep them alive. So emergency medicine gives you this opportunity for invasive procedures before the other specialties can jump on the patient and do these procedures. Shift work and set hours. Some physicians, they don't like the shift work, and some, they actually like it. I mean, when you do shift work, you have free time to do whatever you want at the rest of the day. You have 8 hours or 12 hours, I mean, it depends on the institution that you work in. So it's something advanced for you as an emergency physician to work in the shift work style. So what's the downside to emergency medicine? It depends on the different physicians according what do they don't like about the emergency medicine. Some physicians, they don't like dealing with difficult patients. They said because we are exposed to the street, so anything can happen. I mean, altercations. I mean, fire guns, or some clashes. You can deal with this, which some physicians, they don't like this type of dealing of difficult patients. Finding a follow-up or care at discharge time, it's kind of challenging you as an emergency physician when you try to explain to the patient, and before explaining to the patient, when you try to find a follow-up for this patient who is about to be discharged. Let's say this patient has a fracture, for example, in the scaphoid bone fracture in the hand, and you want to arrange a follow-up for the patient, either like with the plastic surgeon or with the orthopedic. So it's kind of challenging. Some physicians, they find this as a downside to find a follow-up or care at the discharge time. Contact with the management groups. This is one of the also challenges that you may find during your shift. You have to keep calling and following up on with the charge nurse, with the admin people about like shifting the patient to to the floor or ICU. And the last thing, it's a malpractice target. We see a lot of patients. The flow is high, so there will be a chance that even if we are taking our best care, giving the patient best care, there could be a place for malpractice, which happens in most of the specialties. But this is also one of the downsides to the emergency medicine. So how about the lifestyle? It's a kind of two sides of a coin. So well-defined shifts. Usually you are not on call, so you're only just working a shift for 8 or 12 hours, and that's it. There's opportunity for some part-time employment. Depends on your contract with the institution. So once you are done with your shifts, you also you may go for some part-time doing some shifts outside your institution. Evenings and nights, some physicians, they don't like to wake up in the morning around 7 o'clock or 6 o'clock to start the shift around 8 o'clock. And on the other way, so some physicians, they don't like to work on evenings, nights, and even during holidays, for example. They don't like to work during that time. But it's kind of balanced. So if you work in weekdays, so you may get some weekends off, and the vice versa. So if you work on the weekends, so you may have some free time during the weekdays. So going to what like the top reasons for emergency department visits, this was, I found this in one of the websites, but it depends from a hospital to another, but mainly the top reasons for ED visits are abdominal pain, chest pain, fever, headache, back symptoms, shortness of breath, leg pain, vomiting, trauma, weakness, or like some focal weakness or deficit. So these are like the top reasons for the ED visits. You may add any chief complaint to this list, and it is not in like from the most to the least. I mean, I can say we can see all of them, maybe in one shift. You can see all of these cases. Okay. Now I'm gonna I'm gonna talk about few some emergency topics that my friends and colleagues, they're gonna teach you individually in each system. So I picked up like a case from each system, which hopefully can be helpful for you. So I'm gonna start with the first one. So case number one, so 60 years old male with a history of hypertension, diabetes, who is presenting with sudden chest pain, which is central, radiating to the left arm, started 1 hour ago, and it is associated with dyspnea and nausea. On exam, the patient looks in severe distress. Chest auscultation is clear bilaterally and no focal tenderness on palpation. So when the patient comes to your ED complaining of chest pain, at the triage, when they take the vital signs also, and they know that the patient is high risk for having some coronary artery disease, for example, having a chest pain, they will do an ECG. The ECG is cheap and gives you huge values about what the patient could have. So when you, going back to our patient, so the nurse at the triage, they did an ECG, which shows this one. Just take a look on this one, and at the left top is actually the lead one, and at the right side of it is the AVR. If you go down there, because it's kind of erased, the AVL, and left to the AVL is lead 2, and lead 3 is below the lead 3 is below lead 2, which is at the left side of the AVF. So just take a quick look at this ECG, and what do you guys think about this ECG with a patient who's 60 years old with a history of hypertension, diabetes, who is having mid-sternal chest pain radiating to the left arm and associated with shortness of breath and nausea? So if you think about myocardial infarction, that is correct. So it is, it's a lateral wall myocardial infarction. Why I said the lateral? Because if I go back about to this ECG, you will look at the, is my pointer, can you see my pointer? Let's see, okay, I think, yeah, here we go. So lead 1 and AVL, they have the ST segment elevation, and also look at the V5, kind of elevated hyperacute, also T-wave. But basically, one, you need at least 2 leads, consecutive leads, like 1 in AVL, and you can call it ST segment elevation, which is the lateral wall myocardial infarction. So myocardial infarction, especially the lateral wall, it's a blockage of the left main, the left circumflex coronary artery, which supplies the lateral wall of the heart. In each case, I will go with what you just need about this case. For example, I'm not going to list the whole list of the investigation lab work for the patient. I will just add whatever the patient needs. So for this patient, whatever you need is like to do 12 leads ECG, which we already done at the triage. You need a troponin. It's one of the cardiac enzymes that will give you a hint if it is high, and then the patient went for the cath lab or the percutaneous coronary intervention, you may then trend the troponin. So if it's high, then hopefully that after doing the cath and putting a stent, so this troponin can trend down. And also you need a renal profile or kidney function, because these patients, when they go to the cath lab, we know it's emergency. Sometimes we don't wait for this lab result, but if you still have a time and you have some quick test to give you the creatinine or one of the renal function tests, it's better to do it because this patient will have contrast for doing the cath. And how can we treat this patient? Always remember to stabilize the patient. This is our job. This is our job. This is our job to stabilize the patient, starting with the A, B, C, D. Make sure that the airway is intact. Make sure that the patient is breathing well. Make sure that the circulation, the patient is not hypotensive, the patient is not tachycardia, and also check about D, which is the neurological status of the patient. Then you will give antiplatelet, which is aspirin and clopidogrel, or what we call it Plavix. Then giving anticoagulant, analgesia if the patient needs something for pain. And right away, when you see this ST elevation in the ECG, so you have to call the cardiology to do a cardiology consultation. And the definitive treatment for this patient who is having an MI or myocardial infarction is to do the PCI, going to the cath lab. And if they have a stenosis, they may put a stent. Okay, so next case. Next case is a 75 years old female with the history of a brain stroke, hypertension, who is coming to the ED with the right side weakness of the arm and legs and face 1 hour prior to arrival. Also, her daughter states that she is unable to understand what she says. So the mother is kind of confused, or she is uncooperative. She doesn't understand what her daughter says. On exam, the patient is weak on the right side and unable to lift her arms and legs, and also she is confused and not cooperative during the exam. So by giving this history and this brief hint from the examination, what could this patient has? So when you send the patient for CT scan, so this is the image that you got on the brain CT or brain or head CT. So if you think about a stroke, so you're correct. So cerebrovascular accident or strokes, why this patient has this kind of weakness on this side of the body, because it is due to non-functioning brain tissue. So there is a brain tissue, an area in the brain that is not well perfused, which causes this type of illness, which is a weakness, and the patient is unable to lift her arms and legs. So just talking briefly about the cerebrovascular accident or the stroke, we have basically two types: either ischemic stroke, which means that the tissue has no enough blood supply, or hemorrhagic, like you have hemorrhage in the brain and there is a bleeding in one of the vessels, which leads to also that the brain tissue does not have enough blood supply and oxygen supply, which can cause necrosis. As we see here in the picture, so basically the MCA, the middle cerebral artery, and also is the most common site for bleeding, most common, arterial stroke. And here, as I mentioned before, we have like hemorrhagic, and this is the ischemic. So you have an area of thrombosis, which blocks the blood supply to the brain, which results in non-functioning brain tissue. Again, as I mentioned, I'm going to just talk briefly. I will not go in deep details about like the investigations, management. So investigations, what you need, if they ask you about one type, only one investigation on one test that you have to do it in a patient who is coming with one side weakness, I'm going to go with the CT brain or head without contrast. It is non-invasive, it is very helpful and valuable, and can give you a quick hint about what is going on and why this patient is weak at that side. So CT brain or head without contrast, renal also profile. What I mean by renal profile, again, is the creatinine. So the creatinine is important for us to make sure that if we, after the CT without contrast, if we want to add another investigation like CT or then MRI with contrast, so this contrast could be harmful to the patient's kidneys. So that's why we order the renal profile to make sure that the patient has no kidney injury, so we can give the contrast. And also coagulation profile, I mean the prothrombin time and the partial thromboplastin time, the PTT. or the INR. So also it gives you an idea if the patient is taking if the patient on any anticoagulant medications such as heparin or warfarin. So it gives you an idea if it is like subtherapeutic or supratherapeutic before giving medication thrombolytic, like for example TPA. Okay, and also we're gonna order MRI brain with contrast, but this does not happen in the ED. You have to consult the neurology and neurosurgery if you have a bleed. Management, again, go back to the basis. Stabilize the patient, A, B, C, D. Make sure that the blood pressure control, and it depends on if it is ischemic stroke or if it is hemorrhagic stroke. Each one of those have targeted blood pressure. You have to keep this blood pressure to this target for either types of stroke. So once you consulted the neurosurgery and neurology, make sure that the patient is stable, and then you can disposition the patient. This patient should be admitted to the hospital. Again, if you have a patient with the intracranial bleed, going back to the basics ABC, this patient may need intubation. This is our job, so we have to intervene and stabilize the patient before shifting the patient to the other specialty like ICU or the floor. Okay, moving on. So case number 3. This is a 26 years old male who is otherwise healthy, who was stabbed on the chest by a knife during an altercation at a grocery shop. On exam, the patient is tachypnic and hypotensive, and when you auscultate the lungs, you see decreased breath sounds on the left side of the chest with the jugular venous distension. So the jugular vein is distended. So what do you think about this patient when you have this X-ray? So if you think about tension pneumothorax, so you're correct. So tension pneumothorax, it's a life-threatening air trapping in the pleural cavity. It is mainly due to trauma. It needs immediate intervention. This is one of the life-threatening cases that you may face in the emergency department. Do I need an investigation like lab work? Do I need X-ray? Even without the X-ray, it is a clinical diagnosis. It doesn't have to have an investigation. Once you suspect by history and by examination, and so you just intervene immediately. So as I mentioned in the exam, so decreased breath sounds, and also when you examine the trachea, it is shifted toward the opposite side. And you have the patient is tachypnic, hypotensive, and you have the JVD. All these give you hint about the tension pneumothorax, and your intervention here is a life-saving. So I'm going to go back again to the X-ray. If you see, this is the lung tissue here all the way. It is, and you have this all. This is the air which is from here all the way to here, all the way down. Here's where the air is trapped in the pleural cavity, which is pushing the lungs, the left one, and also pushing the trachea and mediastinum, everything towards the opposite side. And also that's why giving you the symptoms of shortness of breath, and also the signs of JVD and hypotension. So how can we manage this patient? Again, stabilize the patient, A, B, C, D. Make sure that the patient is stable before moving from one step to the next step. From A to B, B to C, C to D. If you have any problem with any point of those, so don't move to the next one until you stabilize that point. So the first thing that you do is the needle thoracostomy, like decompression. You have to decompress the lungs. Use like if you have it in your house, this should be done at the field. Like, for example, by our colleagues from EMS, if they have a patient who is stabbed and the patient is on the street and they have a high suspicion of tension pneumothorax, they can intervene by inserting a needle, like a big needle, like 14 gauge or 16 gauge, and the second intercostal line at the midclavicular line. So how can you know that you are going in the right track? So by hearing the decompression of the lung and all the air is coming out through the needle and feeling the relief. I mean, you can see the patient is relieved from this pressure. Next is going to be the analgesia, because if the patient have a chest pain, they may ask for something for pain, just give them any type of analgesia. And then you have, after doing the needle decompression, is the chest tube insertion. This is one of the fun procedures that we do in the ED. So since we have this opportunity to be emergency physicians, so we have this opportunity to do the chest tube insertion. Okay, so moving on. So case 4, this is an 18 years old female with no history, who is otherwise healthy, presenting with lower sharp abdominal pain, started 3 hours ago. The pain is located in the right lower quadrant, not related to oral intake. What I mean by that, even the pain is there, even if the patient is not eating, associated with vomiting, anorexia, and she denies any urinary symptoms, and she has regular periods. Okay. On exam, she looks in moderate distress. She has tenderness on the right lower quadrant, and also she has rebound tenderness. I mean, vital signs, you may have some tachycardia, let's say. So what do you think about this patient? So this is a young female who is coming mainly, basically with right lower quadrant pain with vomiting and anorexia. And she has tenderness on that spot. So when you do the ultrasound, so this one on the right side is the ultrasound. If you look at here, this is the appendix. So if you look at the appendix here, this is fluid, this black thing, that is fluid, free fluid, which is collected around the appendix. And this is you see the appendix. And if we do also a CT scan, look at this area. I mean, I don't know if it's really clear at your slide, but you may see some fluid. So if you think about acute appendicitis, so that's correct. So acute appendicitis, it's an abdominal emergency. It's a surgical emergency. Mainly affects many young females. Again, going back to the examination, so tenderness in the right iliac fossa and rebound tenderness. So in combination with that, the investigation that you may need for diagnosing appendicitis, CBC, look for leukocytosis, renal profile, and also electrolyte profile. These two things also in a patient coming with right lower quadrant pain, you want to check also for renal functions, also make sure that the patient is not having any acute kidney injury. If she has, like, for example, urinary tract infection, it's one of the differentials. And also if you have highly suspicion for appendicitis, also you ask for ABO, blood grouping, and Sure. Yes, I can see this. One of the comments here. Definitely right. Any patient who is childbearing age, you should order a pregnancy test. Yes, a pregnancy test is crucial in all female patients, childbearing, who is coming with abdominal pain. We should. Why we are asking about pregnancy test? Because of ectopic pregnancy. It is a pregnancy outside the uterus. So this is a good point. Also, we should think about why I mean, I don't want to go in details about the acute appendicitis. It just gives you an idea about the cases that we see in the ER. Again, ultrasound, CT scan, as I put my pictures here, you will see signs of inflammation, fluid collection, thickening of the wall. These all signs of the inflammation. So I saw also one of the comments here, CBC is the complete blood count, which gives you the white count, like white WBCs, RBCs, platelets, hemoglobin, and hematocrit, and other stuff. Management, so how we manage these patients, again, stabilize the patient, make sure that they are stable, A, B, C, D, make sure that their airway is intact, they are breathing normally, they have good pulsation, they are not tachycardic, they are not hypotensive. If they are hypotensive, just give them fluid. If they are tachycardic, give them fluid. Make sure that you have everything ready for the patient. If they are in pain, just give them pain medicine. And when you consult our surgical colleagues and they decide that the patient will go to the OR, it's a good thought that to start the antibiotic just before going to the OR. You can just give 1 dose of antibiotic before going to the OR, and also make sure the patient is NPO, nothing per orally, I mean nothing per mouth. The patient should be fasting, and surgical consult, because this patient, if you have acute appendicitis, this patient should go to the OR. Okay, so do we still have time? What time is it now? Is it time for a break? Because I still have like another 6 cases. So if you want to take a break, so we can take a break.
دكتور محمد, you can resume. الله يرضى عليك.
Sure. Okay.
الوقت طيب.
Sure.
الله يعطيك العافية.
Okay. Yeah. Okay. So moving on to the case number 5. So basically, this is a 25 years old male who is otherwise healthy, coming to the ED with the scrotal pain for 5 hours or 5 hours ago. While he was sleeping, he started to have this pain. He woke up because of this pain. The pain is dull and has no radiation. He took 1 gram of paracetamol, which relieved the pain mildly, but still having the pain. And it is associated with nausea. On exam, the patient in severe distress, when you look at the genitalia, swollen, congested, high riding left testis with transverse lie. What we mean by transverse lie? So normally the testicles, they lie on the vertical alignment. So on the exam, when you examine that patient, you found out that the left testis in transverse lie. And also there is an absence of the cremasteric reflex. Does anyone know what's the cremasteric reflex? It's a reflex which, when you touch the medial side of the thigh, the testis, which is next to the this thigh, should go up a little bit. This is just a normal reflex, which is called cremasteric reflex. So what do you think about this patient who is young, who had a testicular pain or scrotal pain, and you have these findings on the exam. Okay, so if you think about okay, let me just show you the ultrasound. So this is a Doppler ultrasound. If you look, this is the left testicles while the patient has pain. And also this is the right one, which is the patient has no pain. So this is a Doppler study ultrasound. It shows you the circulation or the blood supply to the testicles. If you look at the left, the right testicles, which is the left side of the screen, it shows you the normal vasculature. I mean, the blood vessels reaching the whole tissues of the right testicles. In contrast, if you look at this one here, which has no colors, it means that there is like the circulation mainly is absent, as you see here. So if you think about testicular torsion, that is correct. So testicular torsion is it's a urological emergency. Who are at risk? Those patients with undescended testes, they are at risk. And this is one of the emergencies that you have to intervene. It is time sensitive. What I mean by time sensitive, like up to 8 hours, if you don't save the patient testicles or you don't intervene, the testicles can be necrosed and they're not be salvageable. So even after 8 hours, and when the patient goes to the OR, the function of they are not functioning. I mean, they're gonna be necrotic, and they're gonna take the testicles out. So it is time sensitive. So you have up to 8 hours to salvage the testicles. As you see here in the picture, this is the normal one. This is the normal testicles, and it should not be torsed like this one. This one is the one torsion that we have talked about. Testicular torsion is like twisting of the pampiniform plexus and the vas deferens, which can impede or can decrease the blood circulation to the testicles, which make them necrotic and non-salvageable. So, as I mentioned, it's a time sensitive. In the exam, this is one of the key points. Like if you have an exam and they say the cremasteric reflex is absent in this testicles, this is a test which is a 99% sensitive. What I mean is, if the reflex is absent, this is very high suspicious that this testicle is torsed and need an immediate intervention. So what investigations we need about this patient? Before doing anything, I wrote in the management down there, it's a neurology emergency. You should call the urologist even before starting investigations. Once you suspect and you see it, you have to consult the urology first, and then you can do the Doppler ultrasound, which is the one I showed you, the previous slide. And you can see that the circulation and some ischemia going on the affected testicles. Again, renal and coagulation profile. This patient, if the patient is going for OR, you should have some idea about what is his coagulation status. And also you have ABO grouping. I mean, this patient may need blood transfusion during the operation, so you should have an ABO grouping. Management, make sure that stabilize the patient. Again, A, B, C, D. Then I mentioned urology consult, which should be done before doing the investigations, and that's why I highlighted. Detorsing the testicles. So as I explained before, like normal alignment of the testicles, they are vertical alignment. So, but during the testicular torsion, they're gonna be transverse. So if you can imagine, it is like they are vertical, for example, one of them or two of them. So to detorsing means to put them back to normal position or alignment. It's like you open a book. So like when you are open a book, you detorsing the affected testicles, put it back to the vertical alignment from the abnormal vertical alignment. In case you have like this patient within almost like 8 hours and the urology needs more time to come in, so it's better, it's one of our jobs is to intervene immediately for to salvage the testicles. And also analgesia is important because it is painful, and this patient will go to the OR, the operating room. Okay, so moving on to the another case, which is case number 6. 10 years old male with a history of type 1 diabetes, presenting with altered level of consciousness. The mother states that her son has been vomiting for the whole day, and he had the same issue before and was admitted in pediatric ICU. On exam, the patient is confused, non-cooperative, looks dehydrated, like dry, cracked lips, sunken eye. Patient is tachycardic, and you ask the nurse to do the quick VBG. It is one of the tests that we can do to check for the partial oxygen, partial CO2, bicarb, lactate, and glucose. So by these numbers, I'm going to just tell you that the pH is 7.15, and I'm going to talk about the like a quick overview for the ABG. PCO2 here is 3.7. If you convert it to millimeter mercury, it's going to be 27. And if you look at the bicarb, it's 16.4, which is low. So the normal, so for PCO2, the normal is 40. And we have, if you convert this, it's going to be 27. And the bicarb, the normal is 24, let's say, and you have here 16.4. And the pH is, your normal pH is 7.4, and you have here 7.1, which is in the acidotic range. So if you have acidosis with this pH, but you want to know what's causing the acidosis, is it the increasing of the CO2, which is not the case here, the CO2 is going actually down, or the dropping of the alkalytic, which is the bicarb, which makes it acidotic. And this is the one causing the acidosis, is the dropping of the bicarb from 24, now it's going to 16. So you have a metabolic acidosis, and you have a patient with the RBS also of 25 here, which equals to 450 milligram per deciliter. So definitely you would think about DKA. It's a metabolic emergency. It's either undiagnosed, could be the first time. So you may have a patient who is coming with these symptoms and never diagnosed with diabetes. And when you do the VBG and you see these values, so you might think, oh, this is a DKA, and this patient has been never diagnosed with DKA. So it could be either undiagnosed, like first-time diagnosed, or recurrent diagnosis. Sometimes patients, they are not compliant with their medications, they are not strict with their diet. So it's either undiagnosed or like recurrent diagnosis. So quickly, investigations, what you need to know about this patient, basically, the RBS, which is a random blood sugar. You want to know what's his or her blood sugar level, CBC, to check for any like leukocytosis. If this patient having some electrolyte abnormalities, especially the potassium, you have to know about the potassium, because when you correct the DKA, you should keep an eye on the potassium. And also chemistry, what I mean is like renal function, liver function, urine analysis also to check for ketones, which is it's one of the main criteria to diagnose DKA, is ketonuria, which is ketone in the urine. And also you need a VBG, as we showed it in the previous slide. And also the DKA could be precipitated by like infection, or that's why we ordered the CBC to check for leukocytosis. So how we manage these patients? So this is one of the, as I mentioned, metabolic emergency. Stabilize the patient, make sure that patient is stable, A, B, C, D, and start an insulin infusion. I'm not going in details about this because I'm sure my colleagues, they can talk about it like in details. So insulin infusion, IV fluid, treat the underlying cause. If the patient has sepsis, if the patient has like any sort of infection, any cause or any source that caused the patient to have a DKA, you treat that underlying cause. And this patient definitely needs to go to the ICU. So it's an ICU admission, either pediatric patient if he is young enough for pediatric, or if the patient is adult also, should go to the ICU. Okay, so briefly, I'm gonna just, I have 2 slides about this acid-base disturbance. I'm not going in super details. I just want from you as medical students, interns, nursing, and emergency medical services, at least to have an idea about the acid-base disturbance. So when you have an ABG or VBG, regardless, I mean, ABG or VBG, they are, we can use either one in the ER, and even we don't need an ABG in the ER because it's kind of invasive. And the VBG will give us the values that we want. It's not like the ICU, like when the patient is intubated and you want to know the PO2 and if the patient need any change in the mechanical ventilator. Sometimes we may need the ABG, but not all the time. What we need, VBG, it's easier for us, and it can give us the values that we want. So if you look basically at the VBG, look first at the pH. So if you look at the pH, as I mentioned before, 7.4 is the normal number that you should know about. If the number is below 7.4, so this is an acidosis. Acidosis, it has either respiratory or metabolic acidosis. If the pH is more than 7.4, so it's an alkalosis. And again, it's either respiratory alkalosis or metabolic alkalosis. So the word acidosis, so what makes the blood acidotic mainly is either dropping of the bicarb, as in our case, which can cause metabolic acidosis, or increasing of the CO2 more than 40. More than 40 of the CO2, it means that the patient is retaining the CO2, which can cause respiratory acidosis. And on the other hand, so the alkalosis, which can be caused by increasing of the alkalytic, which is the bicarb, which is a metabolic. Always the metabolic goes with the bicarb. The bicarb is the one for metabolic, and the CO2 is the one for respiratory, a clue for respiratory. So if the CO2 is less than 40, it means that the CO2, the patient is washing the CO2, is taking off the CO2, which makes the blood more alkalotic, or increasing the bicarb in the blood, which make it metabolic alkalosis. Again, metabolic acidosis, if the PCO2 is less than 40, as our patient has, because the CO2 was like about 27 or 26, so it's less than 40. So the patient is trying to compensate. So the patient has metabolic acidosis because of the DKA. I mean, bicarb is low. And if you look at the CO2, then it is also low. That it means the patient is compensating. What meaning of compensating? Means that this metabolic acidosis needs to be neutralized. I mean, this acidosis should be taken out. How can we take out the by respiratory compensation? I'm not going in details about the compensation because it has a lot of formula and just the one I want to mention in the next slide about metabolic acidosis. It's either normal anion gap or abnormal high anion gap. quickly the renal respiratory acidosis. So if you have a respiratory acidosis, it means we have a lot of CO2 retained in the body or in the blood, which means that the patient is retaining CO2. One of the examples why the patient have respiratory acidosis, those, for example, on opioid intoxication. So they have respiratory failure. Any patient who has respiratory failure, unable to take a deep breath or respirate by him or herself, they will retain the CO2 and the blood will be acidotic. So by having the bicarb more than 24 milliequivalent per liter, it means that the renal is compensating this respiratory acidosis, it's trying to compensate. The other thing is metabolic alkalosis. Is, as I mentioned, alkalosis, it means that the pH is more than 4, and alkalosis could be either by increasing of the bicarb, which is the alkalotic, or decreasing the CO2, which is the acidotic. So increasing the bicarb as a case of metabolic alkalosis, like for example, if you have a patient who is vomiting, so these patients, they are taking all the hydrochloric acid out by vomiting, which keeps the blood alkalotic. But how can the body compensate? By respiratory compensation. So you have more alkalosis, more bicarb. The body wants to neutralize, so the body will increase the CO2 in the blood. And that's what we call respiratory compensation, by retaining more CO2. And the last thing is going to be respiratory alkalosis. Respiratory, it means, a clue for it, it's the CO2 lower than 40, and alkalosis, as we mentioned before, it's more than 7.4. A good example for respiratory alkalosis is the patients who are like hyperventilating. Those who are hyperventilating, for example, aspirin toxicity, panic attack, they will just breathe fast, rapidly, and they will take all the CO2 out, which makes the CO2 less than 40, which makes the patient respiratory alkalotic. And if you have a bicarb less than 24 milliequivalent, this means that the body tries to compensate by doing renal compensation. I will not go in details about, as I mentioned before, these, they have like formula and how much the compensation is between the respiratory and metabolic. I will just give you one more slide about this metabolic acidosis. As I mentioned, we have two types of metabolic acidosis. It's a normal anion gap. Anion gap is, how can we know about the anion gap? The anion gap also has a formula. It's the sodium minus the chloride and minus also the bicarb. So if you take the bicarb and chloride and you submit them together or adding them to each other and then subtract them from the sodium, you will have a number. This number, if it is 8 plus or minus, 12 plus or minus 4, that means it's a normal anion gap. So we have some examples about normal anion gap here in this table. One of them is diarrhea, renal tubular acidosis, adrenal insufficiency, chronic kidney diseases, intestinal or pancreatic biliary fistula, hypoaldosteronism, and spironolactone ingestion, prostaglandin, and some other medications. These are metabolic acidosis with normal anion gap. For example, if you calculate the anion gap, you will see it like 12, this number. But if it is higher anion gap, which is more than 12, let's say 17, 18, 20, we have a good mnemonic for that. It's called CAT mud piles. This mud piles that we know about from mid schools, and they added also CAT, C-A-T. So C equivalent to carbon monoxide, cyanide, toxicity, or congenital heart disease. The A, which is the aminoglycoside antibiotic. T, theophylline and toluene. The theophylline is one of the medications used to treat asthma, and toluene it is a substance that is present in glue. And you have mud piles. M for methanol, it's one of the toxic alcohol. U for uremia, So if you have uremic encephalopathy, like abnormal kidney functions and altered level of consciousness in the patient, so this is uremia for you. D, you have DKA, diabetic ketoacidosis, is like our example. If you calculate the anion gap, you will see high anion gap. It's one of the most common examples for the high anion gap metabolic acidosis, and also alcoholic ketoacidosis and starvation. P for paracetamol and toxicity, paraldehyde and fenformin. I for iron and isoniazide, which is a treatment for TB, inborn errors of metabolism. L for lactic acidosis, E for ethanol and ethylene glycol, and both of them are toxic alcohol, and S for salicylate or aspirin toxicity. So this is just a brief talk about the VBG and how to interpret the results. Okay, 3 more or 4 more cases to go. Okay, so case number 7. So this is a 49-year-old female who is otherwise healthy, presents with right leg pain and swelling for 1 week. She takes oral contraceptive pills for 3 months. She had open tibial fracture fixation surgery 2 years ago. On exam, the patient is tachycardiac, and the right leg is more swollen than the left one, and it is erythematous, it is red and warmer, and also it is tender. The rest of the exam is unremarkable. Okay, what do you think about this patient? And if you do an ultrasound for this patient, you will see this. As you look here, so these are like 2 different pictures. So if you look at this one individually, for example, so this is one of the veins in the leg. It's a big vein, and this white thing, the hyper dense here, hyperechoic. Hyperechoic. We call this in terminology in ultrasound. It's called hyperechoic. It means like it is shiny or white. This is a blood clot, actually. So when you do an ultrasound, how to check for thrombus? So when you go to the vein, make sure it is compressible. Like when you take the probe of ultrasound and you press on the vein, make sure it is compressible. What I mean compressible, like when you press on the vein completely, it can go all the way touching each wall, like kissing the wall. But in this case, when you press on the vein, you have this blood clot which prevents the vein from collapsing. So if you think about DVT, that is correct. So deep venous thrombosis, or DVT, it's an obstruction of venous supply of the lower extremity by a thrombus. What are the risk factors for having a DVT? Presence of central venous catheter, like if you put, for example, central line, either femoral, mainly, this is one of the risk factors. Malignancy, trauma, if you have a fracture, a repaired fracture, like in our case, that we have this patient who had a tibial bone fracture fixation repair. Immobilization is also one of the risks. Being pregnant also is putting the patient in high risk for developing a DVT. And the oral contraceptive pills, which our patient is taking, the oral contraceptive pills puts her in high risk for DVT, or deep venous thrombosis. And also inherited thrombophilia, like any blood disease can make the blood highly coagulable, like thrombosed. We have some inherited diseases like protein C deficiency, protein S, factor V Leiden disease. We have some other like coagulopathies can put the patient in risk for the DVT. As you look here, this one, which is the affected leg, which is swollen more than that one, and it is red, as you see here, you see this erythema or redness in comparison to this one. And if you palpate this leg, you're gonna find it tender. So investigations, what we ask for this patient, again, renal profile, I mean, creatinine is one of the friends in the ER. So in case this patient needs anticoagulant, so for example, warfarin or the heparin, also the enoxaparin, you should also check for the renal profile. Okay. Then coagulation profile, you ask for coagulation profile, PT, PTT, INR, Doppler, ultrasound of the lower extremity, as we did to see for the compressibility. The thrombus will not allow you to compress on the veins. Again, the management, stabilize the patient, going back to ABCD, anticoagulation, and this patient needs to be admitted. So regarding this anticoagulation, I mean, if you want to give the patient heparin, once you see a blood clot or thrombus, you may start, I mean, at the bedside, because we have this opportunity as an emergency physician to do a bedside ultrasound to check for the compressibility of the veins. And if you see a vein, that big vein, like the common femoral or the popliteal vein that is not compressible, and you see a clot, you may start the anticoagulation. You should start an anticoagulant medication before sending the patient for a formal ultrasound, Doppler, in the department. This is one of the steps of stabilizing the patient. And as I mentioned, this patient should be admitted. Okay, moving on. So case number 8. So this is a 33 years old female, pregnant, gravida 0, para 1. She's a 35 weekers with a history of hypertension. She is presenting with vaginal bleeding and associated with abdominal pain. On exam, the patient looks in severe distress. She is tachycardic, hypotensive, and she has on palpation generalized abdominal pain. So this is one of the key points and to look for, like if you have a vaginal bleed in the 3rd trimester and you have a patient who's associated with abdominal pain. So this will give you a clue about a critical diagnosis. So if you do the ultrasound here and look for the placenta, and you can see we have some free fluid here, and also we have some, the pointer is not working. Okay, so also look here, look for the free fluid all the way down there. So if you put this all together, this patient, pregnant, 3rd trimester, coming with painful vaginal bleed. So what do you think about? If you think about placenta abruptio, that is correct. So it is one of the obstetric emergency in the 3rd trimester. As you see, the fun part of emergency medicine, that we are dealing with different specialties. We know about most of the specialties, how to stabilize most of the specialties before referring them to the specialty they need. So placenta abruptio is an obstetric emergency in the 3rd trimester. The risk factors for developing placenta abruptio is one of them hypertension, as our patient has, trauma, smoking, advanced maternal age, multiparity, and previous history of placenta abruptio. What investigations we need? Again, we'll go to CBC, look for the hemoglobin. If the patient has a bleeding, so check for hemoglobin. Is the patient have a low hemoglobin level that needs blood transfusion? That's a possibility. Renal profile, coagulation, ABO grouping, and also pelvic ultrasound. The problem with pelvic ultrasound that it can miss some retrocecal collection. So the management for this patient is to stabilize the patient. If the patient is hypotensive, just start them with 2 liters of normal saline, If they are actively bleeding, start them on blood, stabilize the patient, and call our colleagues from obstetric. Okay, the one before the last. Okay, so 72 years old male with a history of chronic liver disease who's coming with vomiting, fresh colored blood, moderate amount, 2 hours prior to arrival, and associated with abdominal pain and palpitations. On exam, the patient looks pale, the patient is hypotensive, the patient is tachycardiac, dehydrated, and on palpation, you have epigastric tenderness. Dealing with vomiting blood, which is hematemesis, and we know that we're not gonna ask for endoscopy right away, but I'm just giving you some hints about if you look at this is a huge like bleeding, fresh blood coming from the upper GI. So if you think about the upper GI bleeding, that is correct. Upper GI bleeding, it's a broad terminology. You have like many causes for this bleeding as an upper GI. One of them could be drugs, medications, like non-steroidal anti-inflammatory drugs. Alcohol also can cause upper GI. Reflux esophagitis also can cause this bleeding. Varices, it's either like esophageal varices or gastric varices can cause this bleeding. Ulcer also can cause bleeding, but the bleeding with ulcer, since it's mixed with the gastric secretion, it may give you like changing the color, like not like fresh blood, kind of maybe clotted, and that's it. So gastric carcinoma also, it's uncommon, but still a possibility, and hemorrhagic gastropathy. And you have here list of some other causes of upper gastrointestinal bleeding. So it's a gastroenterology emergency. So what investigations you will ask about this? So again, CBC for looking for hemoglobin, to check for the hemoglobin level, to check for example, platelets if the patient has like low numbers of platelets, renal profile, coagulation profile, ABO grouping. Usually also in our case, this patient has a chronic liver disease, so you may check for liver function test and do the upper GI endoscopy after calling our gastroenterology colleagues. So how can we manage these patients? So again, make sure that they are stable, stabilize the patients. Hypotensive, give them fluid, blood, even if they are tachycardiac. Make sure that they are breathing. Prepare for packed RBC for transfusion, blood transfusion, if they are actively bleeding, or if you see the hemoglobin is below the level that they should be on. Start the medications like proton pump inhibitors, like omeprazole or octreotide. Also start them on octreotide. Some patients with chronic liver disease, if they have ascites, they may start them on ceftriaxone as a prophylaxis for the spontaneous bacterial peritonitis. And if you have a patient who is bleeding, and you may also consider giving the prothrombin complex concentrates just to stop the bleeding, and for sure the gastroenterology consultation. All right, last case before we go. Okay, so 66 years old male with a history of congestive heart failure, CHF, which is a congestive heart failure, diabetes, hypertension, ischemic heart disease, who is presenting with shortness of breath, worsening over 1 week. He is not complaining with his medications, and he has no restrictions about fluid intake. On exam, the patient is tachypneic. He is in severe distress. The blood pressure is high, 220 over 110. The chest auscultation shows crackles on both lungs and decreased breath sounds bilaterally. And the JVD is extended also, the jugular vein is extended. And both legs are edematous to the level of the knees. If you do a portable chest X-ray at the bedside, you may see this picture. So as you look here, look at the heart, so big here, and you look at the both lungs. They are full of like fluids, and the patient with symptoms and the history and examination and the image. If you think about pulmonary edema or flash pulmonary edema, so you are correct. So the pulmonary edema is either cardiogenic or non-cardiogenic cause. Cardiogenic cause, which is in our case here, that is mainly due to non-compliance with the medications and fluid intake. So they don't have restriction about the fluid intake that is given by their primary physician. Needs immediate intervention because of these patients are rapidly deteriorating. And investigation-wise, so you will ask for CBC, renal profile, troponin, where to check for if there is any sort of ischemia or can causing this cardiogenic edema. Brain natriuretic peptide, BNP, it's not that valuable in the ER, but we sometimes order it to see the extent or the severity sometimes of the disease. ECG for sure, echo, also echocardiography is important, and also chest X-ray. How can we manage this patient? Again, stabilize the patient, A, B, C, D. When you see the patient is tachypneic and having this high blood pressure, so you start them on, we call it BiPAP, the non-invasive ventilation. When you connect them to a big machine that push with a high pressure air that pushing the fluids away and relieve the patient's symptoms. BiPAP and nitroglycerin also, it's very helpful. Like when you give it in large dose, it works on both preload and afterload. And also Lasix is kind of helpful. Education and counseling about fluid intake at the time of discharge, and for sure cardiology and ICU consultation. All right, I think that's pretty much of it. I hope I give you some idea, I mean, like introduction about emergency medicine. These are my references, and stay safe, stay away, and thank you.
الله يعطيك العافية دكتور محمد، كانت محاضرة ممتعة ومفيدة وشكرا لك. بس بالنسبة للأسئلة أرسلت لك الأسئلة يصير نجاوب عليها.
طيب خلينا نشوف الآن الأسئلة موجودة. طيب الأسئلة
يعطيك العافية دكتور محمد، شكرا لك. المحاضرة كانت رائعة وبداية موفقة إن شاء الله للسمر كورس. الأخوات اللي عندهم أسئلة لا تسألوها في الشات عشان لا تضيع. في عندكم بتلاقوا الأوبشن حق Q&A، حطوا الأسئلة هنا علشان الدكتور محمد يقدر يلاقيها ويجاوبكم عليها.
ايوه، مسموع الصوت؟
إيه مسموع دكتور، تفضل.
طيب، بالنسبه للسؤال اللي هو سالوه عن هل في اول سؤال كان اللي هو هل الانتي بليتلتس كان خليني اقرا السؤال بس لانه I'm trying to synchronize between اللي هو الكويستشنز والجوال نفسه. دقيقه خلينا نقول اسئله. طيب اتوقع انه دقيقه بس لازم لو ايوه الصوت مسموع؟
ايوه تفضل يا دكتور.
طيب بالنسبه للسؤال اللي هو كان بيسالني على بالنسبه للام اي، هل انه is it always we have to use the antiplatelet and anticoagulant with the myocardial infarction? Yes, antiplatelets they are aspirin and Plavix اللي هو clopidogrel, and anticoagulation it's mainly heparin we use, or we can use enoxaparin, but depends on the institution. Depends on the institution that you have, but yes, we should, when you have a patient who is coming with MI, yes, we should use it. The other question with the same, the other question is there a time window to not use either one, or some vitals or ECG hints? So I'm not, I think my colleagues gonna talk about the giving thrombolytic or we have some rules like need door to needle and door to balloon, but in theory door to balloon is 90 minutes, like from the arrival of the patient up all the way the patient going to the cath lab, it should be within 90 minutes. And if there is no cath lab in your institution and you consider thrombolytic, this is another story that they will talk about it when they explain for you the cardiovascular emergency. Moving to the next question, what is the time frame window for heart muscle death? I think this I talked about it. We don't have a critical time. The only thing that we have this rule, door to balloon is 90 minutes. Like within 90 minutes, this patient should go to the cath lab. There no nitroglycerine. I don't know about this nitroglycerine. Let me check. طيب. Moving on to the questions. In stroke, can we have a name by clinical? Yes, this is a good question. Can you know which artery or which blood supply is affected during the stroke by having the I mean you can know the side of stroke. Yes, in each circulation, if the patient had, for example, you have the anterior cerebral artery, which supplies mainly the lower extremity. So if the patient has weakness in the lower extremity, it means most probably it's the anterior cerebral artery. And we'll talk about this the blood supply and which area is affected when you have a stroke in that blood vessels. But yeah, you can. I know we are emergency physicians, but also we are good neurologists also. Next, what to do if kidneys are bad and you cannot contrast the patient? Okay, so this is also a good question. Like if you have a patient who is having, they have no kidney functions, for example, let's see, if they have abnormal kidney functions and they want to go to the cath lab, for example, to giving a contrast. So you can think about it. Here is one of the reasons why we take emergency medicine. So it's a critical decision making. So would you like the patient to die of myocardial infarction, or this patient can have a kidney injury, they can have a temporary dialysis, and the patient can survive? So for me, I would like to save the patient's life by going to the cath lab and treat the patient and avoid the patient from arrest, rather than to have a kidney injury and then the patient can have a dialysis. And it is a shared decision. I mean, we can talk to the patient, and if the patient is talking and patient is awake, conscious, we can have a shared decision. We can talk to the patient and explain to the patient that you are going to have a cath lab and we're going to give you contrast. Would you like this or that? This is a life-saving, and this is another alternative. So we can do a dialysis for you. I think this is, I think I answered this question. New ATLS guideline, the needle decompression should be on the 5th intercostal space, mid-axillary line. Sure, yes. Still, you are right. But if you are in the field, still you can do the needle decompression with the mid-clavicular line with the 2nd intercostal. There is no harm to do it. But when you are in the hospital, then you can go with the protocols. How to differentiate between appendicitis and ovarian? Yes, this is also a good question. It is kind of challenging. When you have a patient with a right lower quadrant pain. Hello?
أيوة دكتور.
أيوة. When you have a patient with right lower quadrant pain, you have a lot of differentials. One of them is like, it's either appendicitis or you have ovarian torsion. So basically go with the clinical scenario. I know that they are similar in somehow, but if you go with a non-invasive, for example, ultrasound, if you are thinking, if the patient has history of ovarian cysts and this pain is like sharp suddenly, you may go with the torsion initially. You may think of torsion. It's more critical than appendicitis. So if you go with the ultrasound, do the pelvic ultrasound, so you may look for ovarian torsion. And this is, we face it daily. I mean, when you have this case, it's kind of challenging. Like, you don't know if the patient has a torsion or appendicitis. So sometimes the ultrasound or CT can help you with that. So yeah, it's kind of, and the ectopic pregnancy, this is easier. So do a pregnancy test. If the patient is pregnant and having this pain and you do the ultrasound, I'm sure you would reach the diagnosis. It's gonna be easier. Appendicitis and ovarian in cases 3 weeks. In pulmonary edema, why BiPAP and not CPAP? Well, CPAP, it's mainly used for during sleep. So BiPAP has a dual, like it gives you pressure during inspiration and give you a different pressure in expiration, which needs a cooperative patient. You can't use a BiPAP in a patient who is comatose. You can't use it with a patient who is vomiting. So a BiPAP, it's better rather than CPAP. CPAP will give you only one type of pressure, which is used mainly during sleep when the patients are having sleep apnea, one of the type 2 respiratory failure. But BiPAP is the one we use because it has a specific pressure on inspiration and another pressure during expiration. In high lactic acidosis, patients with fever, how can differentiate between sepsis and mesenteric thrombus? This is also a good question. If you have a lactate of 16 and patient is febrile, how you can differentiate between sepsis and mesenteric ischemia? Again, going back to the basics. If you have a patient who is, let's talk about, for example, mesenteric ischemia or mesenteric thrombus, you will have most of the time patient who is known case of atrial fibrillation, who is coming with abdominal pain related to food, and it is tender, you may think of bowel ischemia. Sepsis, it's a terminology. You have it like when you have a source of infection and you have abnormal, like we have a search criteria. I'm sure that my friends also will talk about search criteria. It is like if you have an abnormal in the heart rate, in the respiratory rate, in the temperature. So sepsis is different. So it'll give you that, they will tell you that there is a source of infection. The patient is febrile. Most of the time with the bowel ischemia, the patient is not that febrile, not like the sepsis. What can we use for blood pressure? Yes, this is another also good question. What can we use to control the blood pressure in ER? Well, blood pressure medications to control the blood pressure, either you may use labetalol, which is a beta blocker. You may use hydralazine, nicardipine, all these, and also nitroglycerin helps you with lowering the blood pressure during the flash pulmonary edema. But it is not that antihypertensive as the one we use in hypertensive emergency. And also esmolol, you can use it during the aortic dissection. So these are some examples of medications you use to lower the blood pressure. In STEMI, do we need to give heparin? If you consider, yes, or thrombolytic. Yeah, it's two different things. Heparin is an anticoagulant. Thrombolytics, it's a different. Thrombolytics, you give it if you have a patient who have STEMI and your institution does not have a cath lab and you want to send the patient to a cath lab center within, for example, 2 hours, yes, you can consider giving thrombolysis to the patient before sending to a cath center. But heparin, it's an anticoagulant. You should give it before going to the cath lab. How can we differentiate between lung collapse and lobar pneumonia, pleural effusion on X-ray? This question. Okay, so lobar pneumonia, I mean, we have this from med school, like the lung collapse will pull the mediastinum and the trachea toward the same side, lung collapse. Lobar pneumonia has no effect on the mediastinum and the trachea that much, and also effusion and the pneumothorax will push the mediastinum and the trachea away from the affected side of the lung. I think that's pretty much of it of the questions. Well, thank you so much for your participation and questions and interaction. And I would like to thank you all for giving me this opportunity to give you a brief introduction for the emergency medicine.
شكرا لك دكتور محمد، والله يعطيك العافية. ومن جد استمتعنا في المحاضرة واستفدنا كثير. ونشكر لكم جميعا حضوركم، ونتمنى أنكم تكونوا استفدتوا واستمتعتوا في يومنا الأول. وبكرة بإذن الله موضوعنا مشوق جدا، والدكتور اللي حيشرحه شرحه عظيم لا يفوتكم. وحننزل بإذن الله الموضوع اسم الدكتور اللي حيشرحه على تويتر. ننتظركم بكرة في نفس الوقت في الساعة 7:15، وننتظر أيضاً مشاركة آرائكم على الهاشتاج في تويتر. ويعطيكم العافية جميعاً.